Here's EMT Case 3. We've already done Case 1 and 2. And then in addition to that, we need you to know the definition, signs, symptoms, and management of open chest wounds plus or minus tension pneumothorax. Some terminology here: pneumo, hemo, simple pneumo, tension pneumo, hemopneumo, occlusive seal. And these are all things that you should know prior to starting this case. This case is time and day is now. Doesn't really matter in terms of season or day of the week or time of the day. You have a 5-minute response time. You, again, are a BLS first response unit. There's a transporting ALS unit that's 10 minutes behind you. In the local system, you can go 9 minutes to the full service ER or 3 more minutes past that to the trauma center. It's very similar to our first 2 cases. You're still playing BLS first response role. The transporting unit has paramedics on it, and they're a little bit behind where you are. And in this case, 10 minutes can be a very long time while you're sitting there with a sick patient. You're dispatched to a Delta response traumatic injury stab wound at the Green Hills Mobile Home Park, and there's the cross streets of Mahler and Small, and you're coming out of the firehouse on Prathersville Road, so you have about a 5-minute trip down the street. Your lights and siren are indicated, and the further information you get is that there is a stab to the chest and the cops are not there yet. So now you're making decisions. Does this sound like a potentially life-threatening problem for which you might be able to do some good? Yes. Does this sound like a potentially dangerous situation where you could incur some harm? Yes. And now you need to make a judgment call. And in order to make that judgment call, you need more information. More information. You need to pull that information from every possible source. So anyway, what do you think you're going to end up with having as a patient? Well, you're going to have a stab, which could be hypovolemic shock, could be critical trauma patient. There's probably some need for PPE because, stabs, particularly in the chest, are sucking, spewing, spraying. And then where's the bad guy? Where's the bad guy? An important thing to know. As you pull up on the scene, as you approach the scene, you've got a standard trailer court. So there's going to be narrow roadways with cars parked all over the place. And then you're going to have speed bumps in some cases. This particular trailer court, the road surfaces are uneven, lots of potholes. And so also the thing with neighborhoods and trailer courts is that sometimes the address system doesn't make any sense, and you're looking for lot 20, and on your left is lot 10, and on your right's lot 227 or something. And so a good map that shows the location of every lot in this trailer court would be very helpful. And as you can see, there's multiple entrances, so which one do you pick? So during your very short response time from the station, one of the key things is, where's the location inside the trailer court? But as you pull up, there's 2 deputies there. More are coming. They're waving you in, or you're being told on the radio that it's okay to enter. And the first thing you want to know is, where's the bad guy? And the officers say he's cuffed and stuffed in their car. They have the knife, and there's another deputy holding pressure on this chest wound. Your patient's screaming and cursing, and that's a good thing because we know he's moving air. The patient's a 20-year-old male. You say, what's your name? He tells you. How old are you? He tells you. His brain's working and his lungs are working. He has a rapid, weak radial pulse. His skin is cool, pale, and moist, as you would expect. He already has signs of hypovolemic shock. He's breathing rapidly, non-labored, good depth, no cyanosis. So really a fairly straightforward patient. Again, for case 3, very straightforward. This is hypovolemic shock, but what else is going on? So there's external bleeding to be controlled, and there's also an open chest wound. And you must seal that up immediately with your gloved hand. And then the very next thing you must do is look for any other holes. You must find and seal all the holes. Now, the external bleeding from this stab wound is really not very much, and you're controlling it and sealing the wound with one step. And then where's this guy going to get definitive treatment? Where does he get better? Are the ambulance crew, paramedics going to show up and bring in all their stuff and set up for 20 minutes of treatment on the scene with this guy? No. This is a critical trauma patient who needs to go to the trauma center to be treated by the trauma team. And so that's what's going to happen. And we need to do everything we can to make that happen quickly. So that may mean we need to send someone out to help the ambulance crew find the trailer that we're in. It may mean that we need to go out and help them bring in the ambulance cart. There's anything we can do to help speed up rapid transport. We need to plan for them needing some assistance. In the meantime, until they arrive, we're going to treat him for hypovolemic shock and monitor him for obstructive shock. So now we have two types of shock here. And regardless of whether he ends up with a pneumo or a tension pneumo, he's got to have some lung damage below there. I don't know how you can be stabbed in the chest and not have a punctured lung. So we're going to have at least a pneumo and maybe a tension pneumo. As you start gathering further data and info, you can get some vitals. Vitals don't look all that bad. Get the history of the present illness. Again, this will be a very dramatic story that may or may not be totally true that you're told. But what ended up happening was he got stabbed, and the guy that stabbed him pulled the knife out, and everybody's drunk and high, and the bad guy is in the police car. So fairly standard setup. Things are progressing as you would expect, but always be aware and be wary that other things can pop up. You ask some questions about history and meds, and he really doesn't have any. He hasn't eaten for several hours because he was busy drinking and doing drugs. And so then you're going to gather some data and info in terms of, let's make sure he's fully oriented. You saw that open, bubbling, sucking chest wound, and you sealed it up. His lung sounds were clear in all fields initially. His trach was initially midline. He had no JVD. His belly soft, non-tender, no other injuries noted. So it's a very simple call in terms of how many different things are you managing. You're only managing this one thing. You've sealed up an open chest wound, and you're going to monitor him for the development of a tension pneumo. That's your plan. And so, again, vitals are trending in the wrong direction. Other things you would want to be watching would be lung sounds. Repeat those vitals as necessary and continuously monitor him for decrease or loss of lung sounds and hypotension. If you lose a radial pulse and you lose lung sounds, you're going to need to deal with that tension pneumo by releasing the chest wound seal. When you have a patient with an open chest wound that you have sealed and he develops a tension pneumo as you would expect, you can manage that hopefully by releasing that chest wound. That's going to create a spewing, spraying mess, and you're going to want to be covered up with appropriate PPE for eyes, nose, mouth, as well as gloves and gown and everything. Not gown, but gloves, and cover any your arms and such. And so it's going to be quite a deal. And we're going to hope that when we release that chest wound seal, that the bubble of air, the tension pneumo, is actually going to relieve itself. In some cases that happens. In many cases it doesn't. So the ambulance shows up. Hey, this is Alex. He's 22. He's got a stab in the right upper chest. We've sealed it. He's weak and dizzy, no radial. Lungs are equal and clear. No history, no meds. Been drinking, been doing some meth, some weed. And here's his current vitals. So this is a pretty straightforward handoff. And you need to talk about his drug and alcohol use matter-of-factly, right in front of him, and without being condescending or accusatory. It is what it is. It's pertinent to his medical condition, and we're not drawing judgments about what the guy does in his free time. We're just passing on information about what could be going on. So the medics that get this report should go, wow, okay, so he doesn't have a tension pneumo yet. Let's get going. And that's totally appropriate. Let's just go is freaking out, and we don't need that. But let's get going is a medical therapy. And so they're going to get going. Here's what the inbound report would look and sound like. And you can, again, pause the video if you want to read that. Here's your handoff. I'm absolutely not minimizing these two reports. I'm just saying I'm going to keep the video short. You can pause it if you want to read. Self-debrief, same stuff. Are you clear on what is a pneumothorax? Are you clear on a tension pneumo? Do you really understand the pleura? Because that's the key to this whole thing. So maybe this would be a good time to go back and look at this. Now maybe right now during class you've just had a lesson on this and you're pretty well up to speed. But if you don't see one of these for 6 months, it may be that you're a little fuzzy. And so that would be a good time to go back and check on that. And then transfer the learning. What if he didn't have the open wound? What if he had just impacted his chest on something, broken ribs, poked a hole in a lung? He's still got the same tension, but you can't do anything about it. What would need to be done for that? Here's the written report. Again, I'll let you pause and read that if you'd like. My apology for using so many Cardinal players, but at the time I wrote these, it wasn't quite as depressing with the Cardinals as it is right this moment. Here's your written report for the ambulance, and this is written from the ALS side as well, so you can kind of see how they document things. We're all one big system here. And while even if you're not a paramedic, we're delivering paramedic service to the patient. And so anything that you can do at the non-paramedic level to understand what the paramedics are doing is good patient care. So that's why we do that. We believe that you're smart and you care, and we give smart, caring people information. They will find ways to use it to accomplish goals for the patient. Here's your standard video debrief. And then some questions that you could ask and should ask. When and why did you know he was in hypovolemic shock? What about O2? What about positioning? He was very short of breath. He does not want to lay down. What do you do about that? It's a trade-off between managing his hypovolemic shock and managing his ventilation. And so frequently you get into these sorts of things. There's gray areas all over the place. What if the knife was still in the chest? What if the knife wound was in a different place? Did that matter? What other conditions could be involved? What if he was stabbed on the left side? Could that have impacted his heart? What's cardiac tamponade? Think about those things. And then what if there were more open wounds, not just one, but several, and you've only got 2 commercial chest seals in your bag? Where else can you find additional chest seals that you could use? So quite a lot going on here in this case. And that's the end of this review, introduction of this case.